What is a high-flow nasal cannula? And how do we use it? And where in the spectrum of care on our patient do we start using a high-flow cannula? On the one side, we have somebody that needs just a little bit of support by giving him some oxygen. Well, on the other side, they may need even a ventilator. So where does it go in that middle spectrum? That's what we're going to talk about today. I'm Dennis with Respiratory Sensei, and as the Japanese would say, それはものすごく面白いだよ。それで学びましょう。All right, we're talking about a high-flow nasal cannula, and the question is, when do we really use it? Where does it fit in the spectrum of care? Well, it's really just like a big, fat nasal cannula. It looks like it sticks in your nose. It has nasal prongs. It's fairly comfortable. But the tube going to it is a little bit larger than you might think. And the primary way it works is that we're going to use excessively high flows. Now, when I say excessively high flows, I'm not talking about flows like a cannula. No 4 liters, 5 liters, or 6 liters. We're going to be using things like 10, 20, 30, 40, 50, 60 liters, and even technology is allowing us to go even higher than that. So there are a few considerations as we consider what it takes to run a high-flow nasal cannula. Now, some of these devices out there that you've seen, the popular ones are called OptiFlow and 𝗲𝗿𝗱𝗀𝗻, and probably by the time you watch this video, there's going to be another manufacturer of those. Technology is always increasing. We're always learning more. But those are the common devices that you might have heard of so far or will see in a hospital setting. So what are the considerations we need to think about when using a high-flow device? Well, and specifically a high-flow nasal cannula, if you think about this, if you're going to be taking oxygen and getting it inside the patient's nose at 10, 20, 30, 40, 50, 60 liters a minute, you have to realize that that's too much dry gas. That would cause tremendous drying out of the mucosal tissues and cause damage to the upper and certainly the lower airways. And so one of the main considerations here is that we also have to humidify it. That's why you'll hear it called sometimes not just a high-flow nasal cannula, but a high-flow heated humidified nasal cannula. Those words are sometimes interchangeable. All right, and so we're going to have to humidify the gas. Well, it's not easy to humidify gas that's going at 50, 60 liters per minute. And so to do that, we need to increase the temperature of the inspired gas. And so that's going to be another setting. Instead of also just doing, or only doing, I should say, setting the flow, you're also going to be setting a temperature. And then there's a third setting that you're going to focus on, and that is because we're giving the patient so much flow, we are definitely exceeding their inspiratory demand, and that means they're not going to entrain any room air. Unlike a traditional nasal cannula where we give 2 or 3 liters and they entrain some air and they get an FiO2 of 28 to 31%, we can give 60 liters per minute at a specific FiO2. So most of these devices have some kind of a blender associated with it so you can dial in the FiO2. And that turns out to be the 3 main settings of a high-flow nasal cannula. First, you're going to set the flow, and that's going to be the most important part of that setting, but you can also set temperature to increase humidity, and you can set FiO2 to meet their inspiratory demand. Well, you are meeting their inspiratory demand, but so that you can set a specific desired FiO2. All right, perhaps one of the most important questions that we could answer today, and we will in just a few moments, is when do we use this in the spectrum of care? In other words, as a patient starts to deteriorate, at what point would a high-flow nasal cannula be beneficial and helpful and indicated? But before we talk about that, let's just talk about some of the advantages of a high-flow nasal cannula, and that'll help us to understand when and why we can use it. The first simple thing is that the high-flow nasal cannula is very comfortable when you compare it to using other devices like a mask, like with non-invasive ventilation, and certainly more comfortable than being intubated and put on a ventilator. It looks just like a nasal cannula, except it's kind of bigger and fatter and sits under your nose. All right, so it is comfortable. If the patient's more comfortable as we assist them with their ventilation and oxygenation, then that's going to decrease their anxiety and it's going to decrease their oxygen consumption. And well, we like that. That just makes everything better. The other advantage is that as you breathe in and out, you're always trying to get rid of CO2, specifically out of some of the dead spaces in your pulmonary system. And that's not always easy to do, and especially if you're just relying on the patient to breathe in and out a few liters at a time. However, when we think about putting in a high-flow nasal cannula and using 30, 40, 50, 60 liters a minute, all that gas is not going to be absorbed into the alveoli, so some of it's going to go in and a lot of it's going to come right back out. And with it comes the carbon dioxide. And so it's really good at getting rid of some carbon dioxide that likes to sit in the dead spaces. We call that dead space washout, so it increases that. Now, don't get me wrong, it can't blow off a ton of CO2 for somebody who's ventilatory failure, but it can definitely blow off several points of CO2 for somebody who's starting to flirt with ventilatory failure or impending ventilatory failure. And so it's great for dead space washout. And then, of course, the other thing it can do is it has a tendency to increase the mobilization of secretions. It does this in a couple of ways. One thing is that as we stick all that gas down below the secretions that may be developing in our lungs, when somebody exhales, the more gas there is there, then the more tendency it has to bring up the secretions as you exhale. It also has an interesting side effect. It increases the mucociliary activity of the lungs. Remember that those are those teeny tiny little hairs, microscopic little hairs along the airway. They're always trying to push gradually the secretions up and out. So if we can increase that activity, sometimes that activity is increased by drugs, but in this case, the therapy actually increases it. So that also makes the removal of secretions even better and more efficient. And then, of course, there's the final, most interesting, and the most benefit from a high-flow nasal cannula. And this has been talked about for years in a rather controversial way. And that is that we now have proof that it accomplishes a type of PEEP, or you might call it CPAP. And what we mean by that is that if you're pushing in 40, 50, 60 liters per minute, then all of that is going to cause a certain pressure of the airway, and specifically it's going to cause a little bit of increased pressure in the alveoli. That alveolar pressure causes the alveolar surface area to extend, and then that causes the oxygen and the carbon dioxide to have more space to be able to transmit across the alveolar capillary membrane. And so it really is just like a PEEP. Now, PEEP is really something that we use when we put them on a ventilator. That's the term that we use. If we're not on a ventilator, we're probably going to call that CPAP. And, if you want to compare it to BiPAP, it's like IPAP over EPAP. It's the expiratory pressure. But either way, it's the constant end expiratory pressure. And so it accomplishes a little bit of CPAP. Well, how much? Well, it's estimated that for about every 10 liters of flow that you have, that you're getting about 1 centimeter of CPAP, or PEEP if you want to call it that. And so that means if you have somebody on 30 liters a minute, it's like giving them about 3 of PEEP. Or 4 is 4. 5 is about 5 centimeters of PEEP, and that's why we like it. If you have somebody on 60 liters per minute, it's like giving them 6 of PEEP, and that can change everything for somebody. All right, now the most important question, the most intriguing question is when do we use it and when do we not use it? At what point, what triggers in the patient care do we see that make us think, you know what, we need a high-flow nasal cannula? That's the most important part of this lecture. And first thing I want you to realize is that on one side of the spectrum, if somebody has some respiratory difficulty, probably the first thing that happens to them is that they become slightly hypoxic. Their ABG-PaO2 goes down, their oxygen in their blood is going down. And so the first thing we might do on the end of the spectrum is just put them on a nasal cannula or some mask just to give a little bit of supplemental oxygen. But remember, on the other side of the spectrum is a ventilator. So if they get in ventilatory failure or have profound oxygenation problems, then we may need to intubate them and put them on a ventilator. Now, if you've been in the field, there is something that you're aware of that's in between, and that's called non-invasive ventilation. And so we also have that. That's where we are providing some ventilatory support for somebody who is not quite in ventilatory failure, but their CO2 is climbing and they're becoming quite compromised. They're going in a wrong direction. We don't want to intubate them or put them on full ventilatory support, so we put them on non-invasive ventilator. Some of you have heard of that called BiPAP. You may use different terms, or IPAP with EPAP. So whatever the term you use, we're going to call that non-invasive ventilation because we use a mask instead of intubating them. And so those are the characteristic points that we use as we advance somebody from just needing a little bit of oxygen to needing a little bit of help because they're ventilatorily compromised, and then also needing just full ventilatory support and being intubated because they're in abject ventilatory failure. All right, well, so where does this go? Well, it can go right about here, or maybe even here. Well, it's not an exact science. The point is, it can occupy the space before or after or right around non-invasive ventilation. Because remember, non-invasive ventilation is about giving them a little positive airway pressure, and that's what can be accomplished through a high-flow nasal cannula when you're using 30, 40, 50, 60 liters per minute. As you can go right here. Well, think about this just for a moment. Really, our goal always is to help somebody who's ventilatory compromised from advancing to the point that they are in failure and needing a ventilator. Because of that, as somebody is becoming more critically ill, in other words, they are needing more ventilation help and oxygenation help, we can use this device to perhaps prevent their evolution to the needing of full ventilatory support. So it's a good device to prevent that. We don't necessarily have to jump straight to a ventilator, but we might be able to use it to prevent them from, well, one, needing to go on a mask and non-invasive ventilation where there's IPAP and EPAP, or we might use it in place of non-invasive ventilation just to prevent them from going on a ventilator. And so that's very advantageous. Now, there's another perspective here, and that is that when we put somebody on a ventilator and we have a tube in, we expose that patient to something called ventilator-associated pneumonia or ventilator-associated events, negative events we mean. But it's not really the ventilator that causes the problem. It's really the tube, the intubation. When we intubate somebody, we make them at risk. We expose them to possible secretions and bacteria that can get down into their airway. So we kind of open that area up. And so we really don't want to intubate somebody. That's what we're really trying to avoid. When we talk about ventilator-associated pneumonia, we really should probably call it intubation-assisted pneumonia. Well, if I can use a device such as a high-flow nasal cannula to prevent going there, then that is also helpful. Another thing to consider is that some patients just have a temporary condition that will put them on a ventilator if we don't cut that off. Well, we can use that, for instance, in the case of somebody who has an infection. We're trying to get control of that infection. That might take 8 hours of antibiotics or more. Well, what if we can use a high-flow nasal cannula to intervene just enough so that the infection is gotten control of, and then they ultimately turn around and don't ever even need a ventilator. So you can see the advantages here, but I also want to mention something else. When we have a patient on a ventilator, we certainly want to get them off as fast as possible. So we're always monitoring their parameters. What's their MIP, their maximum inspiratory pressure, their tidal volume, their spontaneous tidal volume, their vital capacity. And when they're sufficient, that's a good time for us to pull them off the ventilator and take the tube out. But there is a concept that you may have heard of. It's called early extubation to non-invasive ventilation. And you've probably heard of that. That's when the parameters are not quite good enough, but we're so desirous to keep them from being exposed to the negative effects of mechanical ventilation and the possibility of ventilator-associated pneumonia that even though their parameters like their MIP, their spontaneous tidal volume, and even their saturation might leave a little to be desired, we go ahead and extubate them. We early extubate them, and then we put them on non-invasive ventilation to give them some support. Well, the high-flow nasal cannula is starting to occupy that space as well. So we might take a COPD patient, for instance, and put them on a high-flow nasal cannula and take them off the ventilator a little early, perhaps, until they get a little bit better. And that decreases their exposure to the risks associated with mechanical ventilatory support and intubation, as we said. So those are some of the great advantages, and that's the space that we can occupy that tells us when to use a high-flow nasal cannula. All right, now when should we not use a high-flow nasal cannula, or when should we stop using it? And this is important to understand. Use of a high-flow nasal cannula is not an exact science, and so it doesn't work for everybody, and we have to monitor all patients that we use it. What I mean by that is if we think about a mechanical ventilator, that is much more of an exact science. We know if we calculate the tidal volume right and get them in the right rate, we are going to ventilate them adequately. We can get those blood gases and their values for their CO2 and their PO2 exactly where we want it just by making a change. But that's not the case with a high-flow nasal cannula. We might think we can put them on and give them a certain flow and clap our hands and say we've done it. So we're fine, we'll go away and go to lunch. That's not so. We don't know why, but for some people, a high-flow nasal cannula just doesn't cut the mustard. And so you can't just put them on and walk away and forget them. You have to monitor them very closely to see if they're tolerating it and see if it's actually functioning. For some people, it's like a panacea. It just solves everything. For others, it just doesn't work. Well, for that, you're going to have to watch the patient. There's a couple of things that you're watching for. One is that you're certainly going to watch any kind of evidence of oxygenation, their saturation. You might even do a blood gas. Naturally, if it's not where you want it, the oxygenation, then you can turn up the FiO2. That's what you can do. And you can turn it up. You're already getting a little CPAP from the high flow, but you can also now turn up the FiO2 to try to meet their oxygen needs. The other thing, and this is the more important thing that you're going to want to watch, is that how do they look? Do they look like they're exhibiting labored breathing? Remember I said that's not an exact science. It's not like getting a gas and thinking, I can tell I need to change something. Certainly you can use a gas. If the CO2 is starting to climb, you can increase the flow rate, and that'll blow off some of that. But mostly you're just looking at the patient. If they look like they're experiencing labored breathing, their abdominal muscles are being used excessively, and their accessory muscles are being used, well, then the answer there is to turn up the flow. Remember, the flow rate is the primary adjustment you're always going to make. It's the most important part of the therapy. So you can turn up the flow, but once you get about 50, 60, start hitting a max as far as we understand therapeutically, and that's when you're going to have to come to the conclusion that this is insufficient. You're going to have to use something like non-invasive ventilation, but really probably you might have to intubate and put somebody on a mechanical ventilatory support. And so that's the summary of when and how we use, the advantages and some of the benefits, and some of the contraindications associated with using a high-flow nasal cannula system.